Welcome to the EHJ Today at Cardiology Update in Davos 2017. I'm Christian Matter, Professor of Cardiology at the University Hospital in Zurich with the specialty atherosclerosis, acute coronary syndromes, and I'm very happy and honored to have the guest and friend with me, Professor Thomas Suter from Bern, who is Director of the Heart Failure Program there and a long-term cardio-oncology expert. Thomas, you were the lead author, the lead last author of the most recent position paper on cardiovascular toxicities of cancer treatment of the ESC. Could you quickly sketch your motivation or the general motivation of writing such a position paper?
Yeah, we had the opportunity from the ESC to focus on this really new area, that is cardiovascular side effects of cancer treatment. And this is sort of an exploding area. The reason being, number one, our colleagues in oncology are extremely successful and these patients survive. Number two, we have more and more cancer treatments that have an effect not only on the cancer, unfortunately, but also on other organs, and in particular on the cardiovascular system. So
on one side, toxicity, which is bad, but much better survival of and success of the cancer therapies.
Indeed, and that actually leads to two issues. That is, we see patients with cancer who have cardiovascular side effects during cancer treatment. But we also see a lot of survivors now who face cardiovascular complications after the cancer treatment. So it's basically two issues which we have to cover, and that's what we try to do in this position paper too.
And the two issues are the acute, as you said, and the long-term chronic sequelae after a therapy. Could you quickly sketch the short-term, the acute complications that are most common in this context?
Well, what people are most concerned with are cardiovascular side effects in terms of cardiac dysfunction and heart failure. And in particular because this has a bad prognosis and is known for quite some years, I should say. However, I should say with some of the newer treatments, we have other issues too, such as hypertension, cardiovascular side effects in the vasculature, i.e. myocardial ischemia. We have issues with arrhythmias. We have issues with pulmonary hypertension. So the spectrum is actually quite big.
You're an expert in cardiomyocyte metabolism, and therefore you are actually very well suited to talk to us about why we have particular cardiac side effects with tumors. Could you perhaps expand a little bit upon that? Perhaps look at breast cancer treatment or tyrosine kinase inhibitors, just a glimpse?
Yeah. It's quite diverse, and it really depends on what drugs you're using. Going to the conventional cancer treatment, chemotherapeutics, most of the ones which are of concern, and I'm talking about anthracyclines here, are actually leading to loss of myocardium. With all the sequelae we know with impaired remodeling over the long run and bad outcomes. With the newer treatments, you mentioned breast cancer, for example, trastuzumab, we have a completely different mechanism. We have a stunning-like issue where you have cardiac dysfunction in the heart, which probably doesn't lead to long-term consequences for these patients. And that's very important to hammer out, because the actions we take in a patient who has anthracycline-associated cardiotoxicity are completely different from the ones we take when a patient has, for example, trastuzumab-associated cardiac dysfunction.
Yeah. Would you sign the notion that we are perhaps not as specific with some of the target therapies, anti-tumor, as we wish to, because we encounter similar pathways in the cardiovascular system, such as HER2 or the tyrosine kinase pathways. So if you do something to inhibit a tumor, we also may do some damage to the heart.
Absolutely, I think you're absolutely correct. And one important point to make here is that the so-called targeted therapeutics, which are the new ones, are indeed targeted to a certain signaling pathway, but that does not mean that they are targeted to the cancer. And they have their effects in the heart too. But having said that, I think it is extremely important to understand the mechanism. The reason being, in some situations, I would accept that a patient has cardiac dysfunction as long as I know that we don't cause long-term damage to the heart. Yeah. And I perceive myself as a cardio-oncologist sometimes just as the facilitator of the oncological therapy if we face these side effects, i.e., I think the important part is to make sure that the patient gets the potentially life-saving therapy.
Expanding a little bit on what you just said, cardio-oncology services, building structures, standardized procedures for diagnosis and monitoring of these patients. What is your take on that as a consequence of this position paper?
Well, I think one of the important things is awareness, and that's on multiple levels. It actually starts before you treat the patient for the cancer. Yeah. You should assess the risk of cardiovascular complication in the cancer patients. And depending on the treatment you're using, they are completely different. But the best thing would be actually to assess the cardiovascular risk, say, well, here we have a problem, and let's face the problem and let's deal with it and do something. What is obviously not a good thing is if you, after treatment, realize, oh, we have a problem here, and we caused major damage to the heart. So I think that's one of the major issues of a cardiovascular service, cardio-oncology service, that you see the patients prior to cancer treatment, you assess the patient, tell the oncologist, look, this is the risk we're facing here, and let's do this and this to optimize cancer treatment. In the end, you have to treat the cancer because otherwise the patient is going to die because of the cancer.
As you said, the optimal communication between these experts, that is key. Probably in addition to that, to have an optimal risk factor control from the cardiovascular side is also an importance that we have to be more aware, and the oncologists also have to be more aware. Could you perhaps spend some words on that?
Yeah, I completely agree. I think we need, for some of the treatment which cause, for example, cardiac dysfunction or heart failure, we need an assessment of the cardiac function prior to therapy, but prior to therapy, not after therapy. Yeah. Another issue is, for example, we treat, and the oncologists treat, older and older patients. Many of these patients have other cardiovascular issues. Cardio-oncology is not only preventing the cardiovascular side effects in the so-called cardiovascular healthy patient, but it's also getting the cardiovascular patient to tolerate potential cardiotoxic cancer therapy if he or she needs it. Yeah. So it's really a multifaceted issue, and I think the issues you face are depending on where the patient stands, but you have to see these patients prior to treatment.
Seeing meaning EKGs, echoes, labs, perhaps a chest x-ray to have a status and then follow upon.
Absolutely. It depends how you treat the patients in terms of cancer treatment. So if you treat a patient with anthracyclines, it's a different set of questions than if you treat a patient, let's say for chronic leukemia, and with some of these newer medications. So it really depends on what the issue is in cancer. Yeah.
Very interesting, Thomas. Could you sketch the key points for our viewers and listeners, perhaps 3 to 5 key points as a take-home message?
So one of the most important things, I think, is awareness. Awareness that some of these cancer treatments cause substantial cardiovascular side effects. Be aware before cancer treatment, assess the patient before cancer treatment, then look at the patients during cancer treatment. And then another point we haven't even touched on here is don't forget the survivors. Many of the cardiovascular side effects are actually becoming manifest only years after the initial treatment, i.e. 5 years, 10 years, 15 years, 20 years. And at least in some parts of Europe, we're not good at really looking at these patients long term. And I think that's something we have to improve too.
So we have to keep the radiotherapy survivors on the radar.
Absolutely, absolutely.
And to, as you said before, optimal communication between the experts.
It's not only the experts, it's actually the GP too, the internist too, whoever takes care of the patient who eventually, and luckily now to a high rate, survives the cancer. We need to keep these issues in mind.
Great. Thank you, Thomas. That was very interesting to have your insight. And thanks very much for giving the push for this position paper that will be crucial for the years to come.
Thank you very much.